which are often very challenging to manage. And hopefully we'll share some insights and some thoughts about how to manage it and cover an entire spectrum of the presentation, the treatments, but also technical pearls from our sage, and also discuss complications with Dr. Archual. And Joey Pipicelli is going to speak a little bit about pearls with regard to therapy, which is such a critical part of the success. So, again, I'm Marco Rizzo. I'm the moderator. Dr. Huang, Jerry Huang, is our is our sage, although a reluctant sage. He's a sage nonetheless. And I've known Dr. Archual quite a long time, and he's coming to us from the Indiana University Medical Center as and speaking on complications as one of our faculty. And again, thank you, Joey, for joining us as well from London, Ontario, at the Roth McFarlane Hand and Upper Limb Center. Just some housekeeping slides. We did vet, and all the conflicts of interest were mitigated, and this is the disclosure information for all of us. For those of you who aren't familiar, we are an independent nonprofit surgical specialty society dedicated predominantly to education, focused on care of patients with musculoskeletal injuries. We do not endorse or promote any product or service of commercial entities. And for those, it doesn't apply for this, but any equipment used in any of our courses is for demonstration and teaching purposes with the intent to enhance the learning experience. You do have an opportunity to obtain CME credit. Because this is a year-long course, the credit will be given at the end of the year. A link will be sent to you 24 hours after the conclusion of the series, and you'll qualify for one AMA credit, 1 hour AMA credit for completion of this program and the questionnaire to follow. Please share your opinions and follow up as we use your feedback to critically assess how we're doing and how we can make things better. There is Zoom etiquette. All microphones have been muted. Please send questions through the Q&A box. I, the moderator, will review and sort questions as they appear, and I'll try to answer some as they come in, but also maybe share some with our esteemed faculty for discussion. Use the chat box only. The chat box is only for faculty and staff. This is our agenda. So I'm working through the opening remarks. I'll introduce with a case. Dr. Huang will then speak on pearls as the sage speaker, and Dr. Archual will speak on navigating complications, and Mr. Pipicelli is going to speak on therapy implications. Hopefully we'll have some time for Q&A at the end, and then we hope to adjourn at the top of the hour. Just a brief slide on learner objectives. We are on YouTube. These are recorded, so you can access the recording. This will be available 24 hours after the conclusion of the webinar. We also are on OrthoTV online, so this is being live streamed and for hand events and more. So this is another avenue for disseminating the talks and for revisiting them. Okay, so that's our introductory slides, and without further ado, I can get us started with an introductory case. Okay. Can everyone see that? Okay. 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 So. Again, I have no relevant conflicts, and I appreciate this opportunity to participate and share and learn. So this is the case. It's a 58-year-old female who sustained a dog leash injury to her right middle finger. She was opening the car door, and the dog got away and twisted and flexed her finger. She's not sure exactly the mechanism. She presented to her local doctor, ER, and was noted to have some suspicion for a metacarpal head fracture, the middle finger. There's also a little fleck of bone on the ulnar side of the index finger that they noted. But interestingly, her primary issue was the PIP joint. She had a lot of pain at the PIP joint. They treated her conservatively. She returned in a week for follow-up and had still pain at the PIP. And at 2 weeks post injury, she presents with these X-rays. Ultimately, she was treated with a splint, further splinting conservative measures and protected activity. Following a period of splinting with a PIP extension splint, she still had pain and stiffness 6 weeks post-injury. At this point, there was a discussion about getting an MRI study, and they obtained an MRI, which showed this is the index finger for comparison. As you can see, the extensor mechanism here, and if you look at the middle finger, there's a bit of a disruption here, in addition to the flexed posture of the PIP and the hyperextended DIP joints. So at this point in time, there's concern, of course, that this could be the beginnings of a boutonniere deformity, or not the beginnings, an actual boutonniere deformity. This is the read. I hope it's showing up on the image, but the read that did highlight the fact that there appeared to be potentially a non-displaced fracture at the base of the middle phalanx. They recommended getting a CT scan. There was a partial tearing of the extensor mechanism, but also they threw in this possibility of a giant cell tumor of tendon sheath versus even possible infection. At that point is when they referred her to our clinic, and this is what her video looked like at the time when I first met her. So now she's about four months post-injury at this time, and maybe what I'll do is I'll ask, well, maybe I'll just keep going. Anthony, what do you think at this point? Are you thinking, are there further conservative measures we could pursue? I mean,
yeah, I think she's probably exhausted that, and you've got decent imaging that suggests there's concern at the central slip. And if she's
yeah,
not, if she's okay with it or interested, I would certainly consider operation.
I think so. Now, Joey, any other therapy modalities we could pursue at this point?
No, I think it sounds like it's been exhaustive.
Mm-hmm. And Jerry, what do you think about the prognosis of another round of conservative treatment and failing like a month or two later? Does that make the reconstruction that much more challenging? I mean, is this the kind of thing, the sooner you get to it, the better?
No, I think all the speakers will talk about this as well. I think these are ones you really want to be patient with it. I think there's no urgency per se, other than patient dysfunction and disability from this. I think there's no kind of absolute timeline. I'd rather be patient with it. I think you have to deal with the patient, make sure they'll be compliant with therapy after surgery, but just make sure they've maxed out. I think splinting, serial casting, we'll talk about some of the modalities later, but I think it's really important to be patient and really feel like you've exhausted everything. I think you could actually operate too early, but I don't think you'd ever operate too late on these injuries.
That's a good point. One thing I think it's important that you highlighted was, at least to me in my practice, is the partnership with the patient. These are injuries and recoveries and post-op that you want to ensure that the patient's going to be able to be able to come to therapy, compliant with therapy, and you want to make sure that they buy into the whole process. It really is. It can be really frustrating if they're not able to maintain or follow therapy to the T. Reminds me a bit of those tenolyses when you have someone with a stiff joint, stiff fingers, and when you commit to a tenolysis for trying to improve motion, the commitment that you needed beforehand on the patient.
Yeah, sorry, just
ahead.
to add there, if she was supple still, then therapy really should try to maintain that extension. And not knowing exactly what therapy entailed, it may be wise to try serial casting with the DIP free to see if you can relocate those lateral bands. Just again, like Dr. Huang was saying, just to buy more time prior to considering any surgical intervention.
And Joey, Jerry, just a quick question about, sometimes we have these difficult discussions with patients. They've tried to get their extension back passively. They're unable to. Do you accept a certain amount as you prepare for surgery? Do you accept a certain amount of stiffness and say, look, this is as good as we can do. Let's move forward, and just recognizing it's less than ideal situation? Or how hard do we stick to our guns about wanting to maintain suppleness before we consider
Yeah, I think it's a great question. I think, and these are really tough surgeries. I think it's really important to have an honest discussion with the patient as far as expected outcome, whether it's a flexor tenolysis or a central slip recon, that we don't have full passive extension. We're not going to get active extension really either. So I think, they've done everything they can. They've done 4 months of therapy. They're like, look, I started at 90. I'm at 30 right now. That's as best as I'm going to get. I've done serial casts. I've done everything possible. They're really compliant. I think you kind of pull the trigger knowing that it's not going to be a great outcome, but they're going to have a better functional finger when we're done, but it's certainly not going to be perfect. But I think it's going to be, you kind of talk about the relationship and just be really honest as far as expectations is really going to be important.
Yeah, those are difficult. And this was exactly the discussion I had with her as I prepared to get this second MRI, just to make sure that this giant cell tumor tendon sheath wasn't a real thing. So I ordered another MRI. There was no comment about that in the report. They basically confirmed this PIP central slip injury that now is bearing more chronic. There's less edema in the base of P2, and but also all this points to a central slip injury that is reflecting the boutonniere deformity. So we did commit to surgery, despite the fact that during that month I asked her to try to get her passive extension completely, completely as good as it could be. And I'll show you a video of her right before surgery. But basically what we're talking about here is these boutonniere deformities, and they all sort of have this common theme of some kind of disruption or laxity at the central slip. That's the beginning, the pebble that starts the avalanche. And ultimately, over time, the triangular ligament becomes lax and stretches out. The lateral bands slip volar. Once those lateral bands lose their sort of balance, I mean, such a delicate machine, the finger, that once you lose that lateral band position for balancing the extensors and flexors, it becomes very, very difficult to get things back to normal the way God made them. And this sort of schematic highlights the pathophysiology. In contrast, the boutonniere is a little bit different, but the swan neck is a bit different. But all these begin with a central slip disruption, attenuation of the triangular ligament, subluxation of the lateral bands, and ultimately resulting in further proximal migration of the central slip ultimately leads to tension on the lateral bands and the hyperextension to form further tension on the lateral bands and hyperextension at the DIP joint. In contrast, the swan neck is the lateral bands are shifting north or dorsal, not volarly, and this can be multifactorial. As Zancoli described it, it could be extrinsic causes, it could be intrinsic problems, and it could be articular problems, as we see in folks with RA. So this can be multifactorial, and I think far and away the swan necks are more common in my practice. This is her 5 months post, and as we're preparing for surgery, and you can see that she's maybe made some improvements of her extension, but she's not quite there at the PIP. Her flexion's pretty good. She's a non-rheumatoid, which I think is important when you're sort of thinking about comparing these to the rheumatoids. They tend to do better than non-rheumatoids when considering reconstruction. Just a brief word on the Elson's test, and in the interest of time, I'm going to try to move along here. So the Elson's test basically assesses for a central slip injury. understanding, of course, that the tightness of the lateral bands will cause them to have stiffness. And this is a nice video of this patient sort of demonstrating an Elson's test on the non-injured ring finger first, and you see how floppy it is. And as you go further along, you'll see when I check the middle finger how tight it is once you take the tension, once you neutralize the PIP and she's pretty rigid. So that's a nice example of what the positive Elson's test is like. We did move forward with surgery in her, and I'm just going to put a brief plug in for the Curtis paper is all worth having. It's a nice logarithmic way of assessing these things, and there's a component of the Matev technique that's part of this as well. But in the interest of time, I'm just going to focus predominantly on this Matev technique, or more importantly, the modified Matev, where we can take a slip, a distal of the terminal tendon, and a cut proximal, and then lengthen effectively the terminal tendon while reinforcing the central slip reconstruction. And it's pretty clever technique. But this is a different patient, of course, so you can has some nice pictures of the technique as it's done, and this is her at tenodesis effect intraoperatively, and this is her at 3 months post-op. So we did this procedure for this patient. This is her at 2 weeks post-op, and at this point she's just beginning to initiate therapy, and this is her at 6 weeks post-op, and this is a demonstration of the short arc protocol with the splint that our therapist created. And this is her at 10 weeks post-op, getting better slowly but surely. Pain is notably better, which is wonderful to see. And I often wonder about the pain because her motion was pretty good pre-op, but I think the tension that's created by the pull is a pain generator in some of these patients. I'd love the faculty's thoughts after we have some time in the Q&A to discuss. And this is her at 15 weeks post-op, finally able to get her fingertip to the palm, if you will, with a good amount of effort. Still a bit of an extension lag. And thankfully, she was able to come back at 9 months post-op, and you can get a sense of much improvement of reflection, but at the cost of a little bit of an extension lag at the DIP. So it's really hard to make these perfect. This is my presentation, basically, but I just want to put a plug in for some of the concerns about the rheumatoid boutonnieres and swan necks are much more complicated for numerous reasons. This is a good study out of Indiana Hand Center from really, really experienced surgeons, Jim Strickland, who was founded the center, and Tom Kiefaber. And basically, they suggested that these are frustrating problems. Boutonnieres in particular are very difficult in the rheumatoids. So keep that in mind as you when you see these. And this is a paper I think that's worth having. So tendon imbalances are significant problems. Early diagnosis and treatment is ideal. Once those lateral bands shift, it's just a much more challenging problem. And I think therapy is essential, of course, and making sure they partner with us in therapy. And perfection is really achieved, and the rheumatoids are the most challenging group. That said, I'm going to let Jerry present next, and maybe we'll save some for questions later when we have the Q&A.
Right. Thank you, Marco. Everybody see my slides there?
Yeah.
All right, great. Right. Great overview and great presentation. So I think certainly honored to be the sage. I kind of make a running joke of this a little bit, but certainly kind of humbled by some of the sages that have been part of the AO webinar series with Dr. Jupiter, Dr. Stern, Dr. Osterman, Dr. Hanno. Certainly have learned a lot from them. Really appreciate their mentorship and education through the years. And I'm certainly excited to share on some of my kind of knowledge and experience on this really difficult topic here. So I think we kind of teach the residents and fellows this. I think the Hand Society meetings, we talk about flexor tendon repair techniques. what to do with them. I think they get all the glamour, all the attention. I would argue that the extensors are oftentimes ignored and a lot more challenging as far as treatment. The tendon is a lot flatter, a lot thinner. Injuries are oftentimes missed. I think some of the boutonniere injuries are patients with a blunt trauma, kind of a finger sprain, and they come in with extensor lag, and it's unrecognized oftentimes because these are oftentimes dismissed. Proximity to bone. So we talk about treatment of phalangeal fractures. We really do everything we can to avoid opening. Anytime we touch the extensor mechanism, we violate the extensors, they get really, really stiff. So really try and avoid violation of the extensor mechanism as much as you can. Dr. Rizzo went over some of the kind of anatomy in this area, but if you look at the extrinsic and intrinsic function, as far as the extensors, it's really a confluence of going from the MCP joint to the PIP joint, having the common extensors split into a central slip and lateral slip, and then converging distally, the two lateral bands converging distally onto the terminal extensor. But this really complex intricacy makes it a lot more challenging as far as treatment, and also try and find that perfect balance between the extrinsics and intrinsics as far as treatment. Dr. Rizzo talked about this really kind of that three-part injury as far as what causes a boutonniere. It's that central slip injury that happens initially. You have attenuation of the triangular ligament. Now your lateral band is now off axis. It's sitting volarly, and that causes essentially a flexion moment arm on the PIP joint and TIP joint hyperextension. So it's really that combination deformity of PIP flexion and DIP joint hyperextension. So it's important to really kind of talk about the joint that's supple with correctable extensor lag and that really stiff joint. Stage one, kind of a Burton classification, talks about stage one being a supple joint that's passively correctable. Stage two, Joey will touch upon this a little bit later on, but that flexion deformity from a lateral band that's sublux, so really trying to correct the lateral band positioning with stretching and therapy protocol. Lastly, if you have a stage three, you're really looking at some type of salvage procedure with a fixed deformity with joint destruction. So what's my kind of overall algorithm? We talked about this was case number one is really therapy, therapy, therapy. Somebody coming in with boutonniere deformity, I almost never jump to surgery. One, I really want to establish that relationship and the rapport with the patient. As far as expectations from surgery, you're not going to have a perfect outcome. Patients will oftentimes ask you, is my hand going to be normal? And you have to be pretty honest with them that that finger is never going to be normal. But before even jumping to surgery, really maximize therapy. We know we want that balance and want that joint to be supple as much as possible. So we're looking at passive range of motion, combination of serial casting and splinting, and even kind of casting for mobilization as some of the therapists will do. Once you've gone past that, then you try to talk to the patient about what's their main disability. Is it the PIP joint? Is it the DIP joint? And especially in that Dupuytren's patient with really bad boutonniere, oftentimes they just want to be able to make a full fist. So they're okay actually just getting better DIP flexions. So I think you might consider kind of a smaller, more minimalist approach, just doing a distal extensor tenotomy, which allows for DIP flexion. And even though you're really focusing on DIP joint, a couple clinical studies have shown that you actually get a little bit of improvement in extensor lag. So you get about 5 or 10 degrees at the PIP joint actively, but you're really trying to focus on making that full composite fist as much as possible. But the main complaint, the main disability is at the PIP joint, you've maximized your therapy, you feel like you've done everything possible, you've plateaued. We're looking at some type of central slip reconstruction technique. I would say again, going back to this is something, a theme I'm going to pound over and over again. Best treatment is to avoid really touching the extensor mechanism, avoid the injury, avoid iatrogenic injury from any type of surgery. I think Don Lalonde has really taught us a lot about treating these boutonniere injuries as far as being really patient and taking advantage of some of the therapy protocols that have changed really what we do. But his approach to doing these is before doing anything, serial casting, just doing everything you can, progressively every week, coming back for weekly cast changes until you get maximal PIP joint extension. Ideally, it's full, but as Dr. Rizzo mentioned earlier, sometimes you just can't get there. You get to 20 or 30, but you've maxed out. Once you've gotten there, you're looking at a short period of static extension splinting to try and maintain that. And then now you start using some type of flexion template. The other kind of concept that is kind of a really nice addition to doing these as you're looking at therapy protocols. You actually put them in relative MCP joint flexion. So by doing that, you're actually increasing the force across the EDC tendons at the PIP joint. So really trying to maximize PIP joint extension power. And after you do that, you're looking at relative motion splint for about 6 to 8 weeks. So for him, it's really about 6 to 8 month process of trying to treat these conservatively as much as possible before jumping to surgery. This is kind of a nice little pencil test. Somebody come in with a boutonniere deformity that's maybe passively correctable. You put them in relative MCP joint flexion at about 20 degrees and see if by doing that they could do PIP joint extension. If they can, then you're looking at proceeding to a relative motion protocol, try to treat this without surgery if you can. If they can't get to PIP joint extension, you're looking at doing serial casting first, go into a static extension splint, maintaining that, and then go into this protocol. So really a stepwise fashion as far as treating these patients. So I'm going to present a case, kind of a really challenging case, 41-year-old female who works as a floor nurse. She had blunt trauma to her small finger PIP joint, kind of that common history of had the injury, thought it was just a sprain, didn't have it treated right away, presented to another surgeon with the extensor lag, and it went through therapy, looked at treatment, eventually performed a central slip advancement. Sounds like more just kind of a central slip imbrication that was done, kind of a littler procedure that was done, combined with the PIP synovectomy at an outside hospital. So post-operatively, patient per history was in full extension for about 6 weeks and started active range of motion protocol. So unknown if there's a flexion template or not, but some type of protocol. But she went through all that and now comes to me another 6 months after her surgery with a 70-degree flexion posturing, 20-degree extensor lag of the DIP joint. But she had really good passive motions. So she's certainly been very diligent about her therapy, doing everything possible. So PIP joint is very supple, but she can't extend. So Dr. Rizzo talked about this. I think your kind of simple procedures are taking the central slip, maybe excising part of it, taking with some of the slack, attenuation, advancing that, or littler centralization. The Matev technique is really, really nice, especially with boutonniere deformity, to both address central slip reconstruction, but also lengthen the lateral bands distally, so you actually let the DIP joint drop down, kind of changing the axis a little bit. I think this particular patient, I was kind of worried that that's not going to be enough. She had the injury that happened a while ago. She's had prior surgery with, presumably lateral band centralization already. Still not enough. It's probably not going to glide very well. So we looked at other options that might be a little bit stronger than what was done before. This is a nice technique, if you're not familiar with it, for the attendees, described by Mod in 2009, taking an ulnar slip of FDS. You basically size of the palm, you do a bone tunnel from volar to dorsal. So now you have a distally based FDS tendon. So now you have a tendon that's kind of a fresh tendon that's never had surgery, never had trauma to it, a little bit more stout, and you suture proximally. So the key is when you do this, you want to be out of the zone of injury. So somebody with prior surgery, you want to be at least proximal to that mid P1 level and suture to a central slip. And when I do that, I make sure the central slip is actually mobilized quite a bit. So make sure you have good mobility and good glide, the central slip more proximally, and suture in there. This is a biomechanical study, so not surprisingly, the FDS slip is a lot stronger. So low to failure is about 82, so about double what you get with a Matev or a primary repair. So certainly a lot stronger. So that's what we did on this particular patient. We did a FDS reconstruction with the bone tunnel. I put him in a full extension splint for 2 weeks. At 2 weeks post-op, even though you want to keep him in extension, I do start a relative motion protocol. I think that's what's changed for me for a central slip. I used to really worry about that extensor lag, but you also, if you don't move the finger, the tendon is going to get stuck again. You're going to get adhesion. So I start a flexion template at 20 degrees each week to increase 10 degrees of flexion. But the key is the moment they have an increased lag, they start going backwards again. They start going to extension again. So I know Joey would touch up on this as well. Kind of like the patient that Dr. Rizzo showed, I really prioritize extension. For patients, it's really hard. They want to be able to grip right away, but they're at a resting extension splint for 12 weeks. I don't allow for any passive flexion until they're 12 weeks out. And again, with that flexion template, the moment they have an increased lag, I go backwards again. I go into extension, full extension again. This patient at 3 months, she's actually pretty happy. She's at 15 degrees of active extension right now, so 15 to 45. We corrected the hyperextension of the DIP joint. So for right now, at 3 months, now we're looking at strengthening, be a lot more aggressive on passive flexion, perhaps a static progressive flexion protocol. But again, it's really important to be really patient with these patients. I think the pearls, again, we talked about timing earlier with the discussion. For me, there's no kind of too late. It's always you're too early as far as the surgery consideration timing. Full extension as much as you can, static serial casting, static extension splinting. Talk to the patient about what their needs are, what's their main disability. Sometimes the distal tenotomy is all you really need. Central slip reconstruction is certainly kind of the full gamut that we talked about. You could excise redundant central slip if you have tissue to work with. Central slip is gone. It's old injury. Centralize the lateral band. Consider Matev, which will also correct your DIP hyperextension. Is the FTS recon really the answer to this particular condition? This is actually case series, even in a case where the FTS is fairly strong. Case series of 6 patients, their final outcome was a 27-degree extensor lag. So again, the best treatment, avoid the central slip. And with that, I'm going to pass it off to Dr. Archual.
Oh, thank you, Jerry. Wonderful pearls. One of the questions that came up from the Q&A was, when do you vary when you start? You sort of alluded to this. Do you vary when you start motion, or do you modify it based on? My instinct is to say, a lot of it depends on how comfortable I am with the reconstruction. But and if so, what's the earliest you would start motion? What's the latest you would start motion after the reconstruction?
I do start at 2 weeks, but it is getting to know the patient. I think for me, if the patient's not going to be able to really follow that kind of flexion template, they get confused. They're not really following the protocol. I will consider keeping the full extension for 4 weeks before doing anything. So I think it's really a kind of every patient's a little bit different.
Yeah, good points. Sizing up your patients, and we'll talk a little bit about that later too. Yes, thank you again. And next up is Dr. Archual is going to speak on the dark side of, not that it's been pleasant so far, the dark
Thanks,
side.
Marco. I'm glad you knew that you could call me if you wanted somebody to talk about complications. So my first case was from my first 6 months of practice, and I was operating, and the anesthesiologist leaned over the ether screen and said, "Hey, can you look at this picture?" And this is what she showed me. This was another anesthesiologist's husband. He had cut his finger. He owned a tree nursery. He cut it with a pruning knife. That's what this is. About a week before this, and his wife, who's a physician, said, "You're being a baby, just leave it alone." And he developed worsening extensor lag at the PIP joint. And I asked him to come to my office. So I talked to him about the possibility of a central slip injury, and that my concerns for complications that could develop would be an infection, a worsening boutonniere, an extensor lag without a true boutonniere, or stiffness in general, and that the PIP joint can be sort of finicky. He uses his hands and was a former military guy, so he was really wanted to be aggressive with treating it. I took him to the operating room, and I cleaned out his PIP joint and the wound really thoroughly, and I felt like it was really nice and clean, and decided to repair it over an anchor. I was really proud of how nice and centrally I got this anchor. I put a Krakow running locking stitch in the central slip, and then dunked it into this anchor that you can see goes in dorsally but tunneled really nice and far into the bone. I would ordinarily manage him in a PIP gutter splint that allows DIP motion. This is a different patient, but the same type of splint that I would use with a short arc motion protocol like the sages have alluded to up until now. At his first post-op appointment with me, he told me he had been lifting some weights and working at the tree nursery, and that he had thrown his antibiotics away after a few doses. And over the course of the next few weeks, he developed a finger that was about as red as this highlighting is. So I had to take him back to the operating room. I had to remove the anchor, which looked infected. I ended up having to put a K-wire in through the dorsal bone and push the anchor out fullerly and go fish it out. We cleaned him out real thoroughly. We were able to re-repair his central slip through a bone tunnel, but hopefully this speaks to some of the trepidation that my colleagues have demonstrated that they have for operating on this type of injury. And although he did luckily eradicate his infection without any further surgery, it was a Staph aureus infection, we had to be more careful with his immobilization and really keep him pretty strictly extended at the PIP joint. This is his motion most recently. This is a few years ago, but he sent me this picture this week. I asked him for an extension picture, but he couldn't figure out what I was talking about. He has about an 20-degree extensor lag at the PIP last I saw him in person.
Anthony, that's a good save considering the trauma and the infection. Boy, it does speak a little bit to how, operating around this part of the hand, the finger. I'm going to quote Peter Amadio. He says every time we operate on a finger, it dies a bit. so
Yes, I have said that many times.
I'll let you go to the second case, buddy. Thanks.
Yeah. Mm-hmm. This second case is a 68-year-old man who has Parkinson's and fell and thought his finger was dislocated. He went to the emergency department and had this PIP joint subluxation. The emergency department numbed him up and reduced it and put him in a big aluminum splint, which he wore for a few days and then removed and then couldn't figure out how to put it back on. I saw him at about 3.5 weeks after injury for the first time in the office, and this was his x-ray. I told him I was concerned with the instability of the joint, that he could have an extensor mechanism injury or, frankly, collateral ligament also, or some other series of structural issues. And I really painted a little bit of a bleak picture about what we may have to do in surgery in terms of repairing and pinning the PIP joint. I found this paper from 1970 from Morton Spinner talking about anterior dislocations of the PIP joint, just like this injury, and the risk to the central slip. And Dr. Spinner encouraged pinning the PIP joint in full extension. This is a case from my boss, Dr. Walji, who centralized the lateral bands for a chronic boutonniere. And that was something else I told the patient that we may need to consider depending on what we found, given that it was about 5 weeks after injury by the time we operated on him. But we opened him up and we found a pretty clean central slip laceration with actually a little bit of distal stump available. And we did a primary repair of that with 4-0 permanent suture. And I arranged his finger under fluoroscopy while it was still open, and there was no gapping, and he really had good motion. The collateral ligaments were fine. So I convinced myself that we wouldn't need to pin this. Again, I put him in a PIP gutter splint with the DIP free in therapy, and he really was doing well in therapy for about the first 2 weeks. And then he came in for therapy, and he came without his splint, having decided with his wife that his finger looked pretty good and he didn't need it anymore. And his short arc motion exercise orthosis was also missing. So this was him at that point, a few weeks after surgery, starting to develop a boutonniere with about a 40-degree lag at the PIP joint. And more recently, this is him. I think he's about 50 degrees at the PIP joint. With his other comorbidities, he's continuing therapy and splinting, but for now, living with it. There's really a paucity of literature on complications after these types of injuries, at least the acute types. This small case series from WashU had 8 patients. 6 of them, and this is, I should point out, central slip fractures specifically, but of their 8 patients, 6 developed arthritis within the follow-up period, which is about 40 months on average. And 4 of the 8, half of them required a second intervention after their initial procedure for reconstruction. This paper from a Japanese group had 40 or 50 patients in their series. They found that age over 40, an associated fracture in the same digit, or a flexor tendon injury on an adjacent digit imparted a modest decrease in their eventual active range of motion, whereas an extensor tendon injury on an adjacent digit more significantly changed their range of motion, owing probably to an extensor quadriga type of effect. So if you want to avoid complications in these patients, make a good prompt diagnosis, and take into account what you feel the patient's compliance will be post-operatively. Make sure you have a good therapist that you trust that's caring for them afterward. Consider pinning the PIP joint. That's certainly something I wish I had done, at least in my second patient there. And respect their concomitant injuries when considering their risk of complications.
Thanks, Archie. Awesome. One thing we noticed that outcomes in patients in Parkinson's in general, for example, when I treated distal radius fractures in Parkinson's patients, their complication rates are so much higher. As you're presenting your case, I wonder in part how much of it applies, how much of it was in part due to this underlying comorbidity, as you alluded to earlier.
Yeah, that's a good question. I did raise that with him and his wife, and they, they have reasonable expectations, but I wish he had turned out a little better.
All too often we see those, they're stuck at 45, 50 degrees and they wallow there. They sort of like wallow in this sort of space for quite a while. But thanks for sharing those cases. Any comments, Jerry, Joey, thoughts?
Actually, a quick question for you, Marco, is how often do you pen to PIP, Joe? I typically don't, but I think certainly for patients you don't trust, it's not a bad idea. I actually had an athlete about 3 years ago who I knew was not going to be compliant. So as central step recon, I did pin it, but I try not to. I do want that early motion if possible, since I've gone to more of a relative motion protocol. But what's your kind of criteria for pinning versus not pinning?
Yeah, I share your thoughts, and I was going to bring that up with Archie as well. I think that the pinning will prevent a catastrophic sort of complication, but it's lower risk, lower reward, in my opinion. I bury the pin, so I try not to invite an infection across. And I try not to leave it in for more than 3 weeks, if at all, if I use it. But I haven't seen as good a range of motion in the ones that I've pinned in the end. And that's just a fundamental experience that I've had. And so like yourself, I moved away from pinning over the years. And I think it's been probably advantageous. In fact, I used to pin sometimes my ulnar collateral ligament injuries for the thumb. I would pin the MP to sort of take the tension off. And I actually found that was not a good idea in my experience. I think it's much better to trust your repair, and they tend to do better in the end in terms of their motion. Joey, do you notice when someone's been pinned for a little bit of time, do they fare worse in your opinion in terms of the motion, or can they overcome that immobilization?
I think it depends a lot on the age of the patient, just because you're skewering the cartilage. And if they're an older patient, I find it's much harder to regain their flexion. But I think one consideration is if you're going to pin those, I know therapy, you don't want to refer them because they're not going to move, but it's important to get them moving the DIP joint to make sure their lateral bands remain centralized and dorsal. And I know they won't have full DIP flexion, but at least some, because they may be volar at the time of the pinning. And I think that might help have a better outcome in terms of extension lag.
Yeah, good points. One of the questions from our Q&A is that, K-wires, and I'd love the panel's thoughts. K-wires predominantly create spot welds in the bone and can limit their outcome. I think in the times that I'm more inclined these days to pin are in the ones that are rheumatoid, if you will, just to give me a little bit of an extra advantage to offset the challenge on their soft tissues. So those would be the ones I still occasionally lean on in terms of pinning. But you could argue that a Parkinson's patient would be a good patient to pin, in my opinion. Good dialogue, Joey. I want to make sure you have enough time to give your talk, and then hopefully we'll have some time for Q&A in the end. Thanks again, Archie. I appreciate it.
Okay, so hopefully everyone can see my screen there. So talk about rehabilitation. Although it's simple, we think so in most cases, but just go over what it should look like and maybe what some considerations on what it shouldn't look like. So no disclosures. So we know what a boutonniere deformity is. It's a disruption of the central slip. Open or close means, and we know in the normal finger, our resting position of the lateral bands are dorsal to the axis of rotation of the PIP joint. And as the PIP goes into further amounts of extension, they become slightly more dorsal, increasing their extensor efficiency. And with flexion, the lateral bands will migrate towards the axis of rotation, but in the normal finger, never volar to it. And so when we have a defect of the central slip, our triangular ligament will tear, which will allow our lateral bands to fall volar. And what's going to happen, as we know, that's going to create tension through the lateral bands, producing a DIP joint hyperextension, and also MCP joint hyperextension will follow, as we've now going to have exaggerated extensor forces also at the MCP joint, and it's going to consequently make this deformity worse and persistent. So these are our primary rehab programs, whether they're repaired or unrepaired, and it's really based on your preference. With closed injuries, the traditional management has been with immobilization for 6 weeks, and patients can either be placed in a cast or an orthosis, and the PIP is in full extension, allowing the central slip to scar down, but they need to be instructed in hourly DIP flexion exercises, again, with the purpose to draw the lateral bands dorsal, which is going to allow the triangular ligament to tighten back up, which is going to help maintain the lateral bands in their anatomical location. What we've talked about already a few times is this SAM protocol, or the short arc motion. And our preference is to begin, within the first 5 to 10 days post-operatively. And we'll provide patients with 2 orthoses. One, the PIP will be immobilized in extension, and patients will be told to frequently bend their DIP joint. And they'll also be given a template orthosis to allow short arc motion, beginning with 0 to 30 degrees typically, and increasing that by 10 degrees on a weekly basis. Now, for a full rationale of this regime, you need to go back and Rosalind Evans back from the late 80s. But in essence, the concept is based on Brand's radian angle theory, that 30 degrees of flexion will allow for about 3.75 millimeters of tendon glide. And this will place about 300 grams of force through the central slip in a normal situation. And we know that repairs can tolerate probably more than 1,200 grams. So if you place the MCP joint in flexion, what you're doing is you're going to detension your long flexors, which is going to allow for minimal active tension through the central slip when they're performing their active extension exercise. This is also going to place your extensor hood in the most efficient position to extend the PIP joint through the lateral bands. So short arc flexion won't tension the central slip until you're getting between 60 and 70 degrees of flexion, unless you had to perform significant debridement in the OR. So another approach, which we also touched upon, was this principle of relative motion. Again, it's been popularized by Lalonde and Merritt over the last 10 years. And really, these two concepts are very similar, this relative flexion and the short arc motion regime. So relative flexion means you're placing the affected MCP joint in 20 degrees of flexion compared to the unaffected fingers, typically in a yoke. And again, this position is going to relax your intrinsics, which is going to allow your lateral bands to be pulled dorsally. And this is also going to enhance the pull of your EDC through your extensor hood, which is going to help tug on the lateral bands, hopefully encouraging them to slide back dorsal. So initially, some have advocated that this could be used for acute closed central slip injuries. And we know that these do predictably well if they're immobilized and they're doing frequent DIP joint flexion exercises. And so I'm not sure this is a good thing to do, because you can see in this biomechanical simulation, which we did at our facility, that flexion produces gapping, which is going to cause the central slip to remain deficient as the PIP is flexed. And so despite having a few case reports in the literature, I think further biomechanical studies need to be done prior to implementing this into practice, especially with closed injuries. I think in the chronic situation, if you're working on trying to help maintain the suppleness of the PIP joint, and we're worried about the PIP getting stiff from prolonged serial casting, this is something that will obviously give you a stronger pull through your extensor hood that can try to recentralize the lateral bands, but with flexion, they're going to keep slipping volar. And so, but this is something to help maintain suppleness, but ultimately when they gain full extension, they should be immobilized to allow the central slip to scar back down. And I think an important point is that it's very difficult to rebalance our extensor mechanism. So it's always better to be cautious. We know that our flexors are 3 to 4 times stronger than our extensors. So regaining flexion is predictable with good therapy. Now, if you look at the acute repaired situation, when we simulated this relative motion and so placing the patient in flexion at the MCP and flexing their PIP, we didn't see gapping at 90 degrees. And so if you're doing these and if intraoperatively there's flexion reveals there's minimal tension and you're really inclined to implement this rehab program, I would do so, but I would still put a flexion block on the yoke, limiting flexion to 30 degrees for the first 2 weeks and then increasing by 20 degrees biweekly. Ultimately, these patients are going to need a second orthosis, so a night extension orthosis, just to help prevent a flexion contracture. But in my practice, I just find that these splints are actually hard to don and doff without flexing the DIP joint or the PIP joint. And so, in the acute situation, they're sore, they're swollen. I just think it's more practical to use a short arc motion regime, like we've previously seen. Now, regardless of the rehab approach that you decide to use, really progression's the same. At 6 weeks, patients can start to wean off their day splinting, but they should continue with night splinting for until they get to 3 months. Passive flexion should not be instructed, if at all, but I would wait until at least 3 months before we start doing that. And a formal strengthening program is rarely required. Now, there's sometimes you can see a few complications with these managed conservatively and definitely operatively, and these includes a chronic extensor lag, attenuation of the triangular ligament, and persistent flexion contractures. So we know that a tethered extensor hood is going to limit proximal glide. It's common after crush injuries especially, and these will lead to a pseudo insertion, which is going to increase your extensor forces at the MCP joint, which is going to result in hyperextension, which is going to worsen the lag at the PIP joint. Now, if you block your MP or if you use a pencil test and near full extension becomes attainable, then that happens because we've increased the mechanical efficiency on the extensor hood. And so in therapy, by simply providing them with a relative flexion orthosis and having them wear that full time during the day will help encourage elongation of these adhesions in the direction of the stresses applied, which should allow them to regain full extension over time. So this is an older case from one of my colleagues. And here's a case of a closed boutonniere deformity, so managed by immobilization. They were immobilized for 6 weeks, and the patient admitted that she wasn't performing her DIP flexion exercises too often. And so she resulted in a persistent extensor lag in this boutonniere posturing, and that's because her lateral bands are volar. And so in these cases, we can try to test if you place their DIP in 30 degrees of flexion, does their PIP extension improve? And if so, they may benefit from an additional 6 weeks of DIP flexion splinting in 30 to 40 degrees to try to help draw the lateral bands dorsal, ultimately allowing the triangular ligament to tighten back up. It's probably best to add relative flexion in combination with this DIP joint splinting to really help pull the lateral bands dorsally. In the chronic situation, we know this is difficult, and these patients always appear on our doorstep because these take some time often to develop. And so when they're no longer passively correctable, we talked about this, we need to trial serial casting to maximize their extension. But I think it's key that once they get almost full PIP extension, it's important that their DIP flexion is full because that means their lateral bands have relocated. And that's when your 6 to 8 weeks of full-time splinting or casting begins. And they need to continue to perform DIP flexion exercises. If patients just can't tolerate the serial casting, then maybe we can switch a week of serial casting, relative flexion splinting, so they're not getting too stiff and we maximize their extension, but ultimately they they need to be immobilized. And then once they're starting to come out of their splint, usually a little bit longer at 8 weeks, then it's probably safest then to put them in a relative flexion splint for another month or two and continue night splinting till they're at 3 months. And hopefully that can help us achieve a predictably good outcome in the majority of situations.
Joey, that's just wonderful. I could listen to that for another hour or so. It's just wonderful to hear those. One thing I like is that splint that you showed, that sort of two ovals. Is that good mainly for just border digits? Is it hard to do those for the middle and ring fingers?
Like a relative flexion splint there with that block. Yeah. So we talk about using a yoke with relative splinting, with relative motion, but that's essentially just a modified ulnar claw splint, but you can put that on any digit. The main point is you don't need to include your other MPs in order to achieve relative flexion. It's just putting them in 20 degrees just to really maximize the pull through the EDC and the extensor hood.
I love that. It just seemed like it would lend itself to, good compliance, and it just seems really, really effective. Let me ask one quick question about, Jerry highlighted this importantly. He's like, once you start to notice a setback, go right back to square one and start all over again. How many times do you think, okay, we've tried this, we've tried it again? At what point do we say, okay, this is clearly not working, we got to go to a different plan?
Yeah, in a mallet finger, we often see a setback. Yeah. Where they have attenuation, but in the central slip, it must be something else. Is their lateral bands just the triangular ligament is still lax? We're progressing them too fast, and the lateral bands are unstable. That's giving us that lag, but their central slip is probably scarred back down. And so I'm not sure I see too many patients kind of going in reverse. I think they're going in reverse, but they're actually adhered, where I think the biggest addition is then putting them in some type of prolonged relative flexion splinting. Another little pearl for therapy is, we have our patients do short arc motion, but their MCPs are in extension, but they really should be doing their short arc motion in their template orthosis with their MPs flexed, again, for those same principles, because otherwise we're going to be tensioning through their lateral bands if they're doing it in extension. It's just those little things. I think that can make a difference in outcome.
Yeah, because I think either my patients aren't as compliant as the Canadians or we're just doing something wrong, because I think I see more failures. I'm more in line with Jerry's concerns are, as Jerry highlighted. I don't know, Jerry, how often do you see the need to go back to square one and then rebuild?
Unfortunately, I do see it, I think, more often than I like to see. I think for these are tough. I think some of the therapy principles Joey highlighted, I think, are great. I think following those principles helps a lot. But I certainly have setbacks, probably not infrequently, but it's not typically over and over again. I think just some patients do need maybe 3 or 4 weeks before you advance them to the next stage. But we can't typically move them forward. But I think as much as I'd like to move them really aggressively, 10, 50 degrees each week, sometimes I feel like I have to kind of moderate that a little bit. They don't typically go all the way back, but they do kind of go back a little bit. It could be they're not doing the exercises correctly, like Joey alluded to. I think that MP flexion definitely makes a big difference. But I do see setbacks sometimes. I think the question for extension of that question is, I think, Joey, from a therapy perspective, when do you feel like, what, surgery has failed? We've done everything possible post-reconstruction. Go back to see Dr. Rizzo or Dr. Archual and kind of see what else could be done. When do you feel like you've kind of thrown your hands up and we've done everything possible post-surgery rehab?
Yeah, usually around the 6-month mark, because you need to give them a chance. But really, if they've been compliant and they just can't maintain, and around the 6-month mark, I'd be pushing to go back to see you.
Thanks for the tips, Joey. We have 1 minute left, so I really can't thank you all enough. Dr. Zabo was online. Thank you, Dr. Zabo. I did want to add a little pearl from Dr. Zabo, who's got probably so much that he could be our sage tonight if sort of recommending when you do pin, make sure you do a little bit more than just pinning. Maybe splint them while you pin or cast them while you pin. So, and I think that's a good sage advice as we end up here at 7 o'clock. So thanks everyone for being here, and thank you all for attending. We've had almost 200 attendees, so thank you all for listening. Thanks, Mackenzie and Abby, for your support and behind the scenes and making these things happen. Again, my heartfelt gratitude to Jerry, Archie, and Joey. And I hope you all have a good rest of your evening. Okay.